So I'm Sheena Larson, and today I'm going to be filming my canine anesthetic protocol. We'll see how it goes anyways with my broken leg. So to start off with, we're going to be preparing Otto for his neuter, and I'm going to be picking out the pre-med. So the pre-med that we have is the hydromorphone, the 10 milligrams per mil, and the acepromazine. I do believe this is also 10 milligrams per mil. And then we are going to be administering this IM. And the reason why this is chosen is because this is what we are most comfortable using for a canine neuter. He's a golden retriever, so he's larger, so the 10 milligram per mil hydro, it'll be a smaller volume. The other option we have is 2 milligram per mil. And then hydromorphone is a opioid. It is a it's primarily on board for an analgesia. It's part of our multimodal analgesia protocol for the perioperative period. He's also going to be going home with some meloxicam, and it also provides it can cause a little bit of excitation sometimes, controversially, because it's used as part of the sedative. And then the acepromazine is primarily used for its sedative effect. It doesn't have any analgesia, but it works well in combination with the hydro. It can make them a little bit nauseous, so they can throw up, but that's actually handy. It can tell us if they had a little bit of breakfast or anything, so that we can reduce the chance of them having aspiration pneumonia. So, and both of these can be administered safely IM. So I'm going to draw those up, and we are going to pre-med Otto, and we'll be done. So this here is Otto. He's being neutered. So we have an IV catheter set. Lexi is going to be helping me with the anesthesia and getting him prepped for surgery. So I have my endo tubes. I do believe that the 57 French is going to fit him. So I want to make sure that it's not going to be too long. So like measuring from the incisors down to the thoracic inlet. So I want to make sure that the endo tube won't go in too far, because it might only start to fill one side of the lungs. So I'm just going to tighten this up. All of the cuffs have been deflated. We're going to be using propofol for the induction. So I'm just going to take a bit of alcohol gauze, and I'm just going to wipe that there. He's panting a bit from the hydro that we had given it as the part of the pre-med. So I'm going to give the first quarter slowly over 30 to 60 seconds. Propofol can take up to 5 minutes to have the full effect, so we always titrate to effect. This here is just saline flush. I was just checking his palpebral reflex there. So I'm just going to administer a little bit more. Oh, big deep breaths, bud. If you administer propofol too quickly, they can temporarily stop breathing. I'm just going to be checking jaw tone. So he's lost the palpebral reflex and he has loose jaw tone, so he should be good to intubate. So I have the 57 French. I'm just going to lubricate the end of that. No scruff, please, Lexi. Up. So I'm just going to take the tongue, hold that, and I can view the larynx. I'm going to pull down the epiglottis and then in. So I can visualize that it's in, and I just want to get him hooked up to the anesthetic machine. So I'm just going to tie this. There we go, and we're just going to spin him around. Oop. I tripped with my broken leg. There we go. So I've hooked him up, and I've turned the isoflurane on to 3, just because when we were moving him, he regained the palpebral reflex. So that's an indication that he's still a little bit light. But as you can see, when I press on his chest, the reservoir bag moves. So that's an indicator that the endotube is in the right place. The fogging up can indicate that it's in the right place. And then I can feel his throat, and that can indicate it's in the right place. I can turn him off temporarily, do that. And then if I was to breathe, and I can feel the air coming out of the endotube when I press on his chest, that's an indicator that it's in the right place. So as he breathes in the isoflurane, he's going to be getting to a deeper stage of anesthesia. I'm just going to be lubricating his eye because he's losing the ability to blink. As you can see, his eyes have rotated ventrally, which is an indicator that he's reaching an appropriate plane of anesthesia. So plane 3, stage 2. And then he doesn't have that, so he's lost the swallow reflex, lost the palpebral reflex, lost the pedal reflex. Oh, little bit of a palpebral reflex still. I'm just going to give him a bit of a breath, and we're going to make sure that he is all hooked up to the appropriate monitoring equipment. I can't smell or hear any movement, so I'm not going to be adding any air to the endotube because there's no leak. We might have to add some as everything relaxes, but right now there's no indication of a leak. So I'm just going to be attaching the pulse ox. And then blood pressure cuff. So I want to make sure that it can go around, and then, but I don't want it to be too tight. That'll be an appropriately sized cuff. The pulse ox is reading 93, which is a little bit low. We want something above 95. Right now, he's just taking shallow, huffy breaths, which is an indication that maybe his anesthetic plane isn't deep enough. And now with the endotube in, with the esophageal stethoscope, there's only one more place for it to go, so I can just open this up and guide along the base of the tongue. And I'm just feeding it in. There we go. So right now his heart rate is 88, which is good. We don't want that anywhere in between 60 and 120. His respiratory rate is still quite high. For respiratory rate, ideally anywhere between 8 and 16. So he's still taking shallow tachypnea type breaths. I'm going to run the blood pressure. There we go. Every time I give him a breath, I'm making sure that I'm not using too much pressure and that the pop-off valve is raised every single time. So for the Doppler, we're going to have this spot here shaved. I'm just going to add some ultrasound gel. We want the metallic side down. I'm just holding it in place with my thumb. There we go. There we go. So we can hear his heart rate now. My pulse oximeter flipped off. I think the battery on that one's dying. Okay, so there we go. There we go. He's taking much more regular breaths. He was panting due to the hydromorphone, but as he gets deeper into the anesthetic, you can see how his breathing is relaxing, and his pulse ox is reading at 99, which is good. We want anything above 95. So I have the esophageal stethoscope, the Doppler, and the blood pressure is reading 111/64. So his blood pressure is good. The diastolic is a little bit low. We would be concerned if that was to drop below 60, but we're going to move him into surgery now. Now Otto is out of surgery. We just have him in recovery. So he's going to be reversing through the stages of anesthesia. That's his tattoo. So as you can see, he's starting to slightly gain back a palpebral reflex. So I'm just going to untie the tube. We still have him on oxygen because we want to make sure that he is well oxygenated. That can help to speed the movement of isoflurane from the lungs. And checking to make sure that he's getting a bit more jaw tone. I'm just going to be checking his temperature because we also need to be making sure that he's not getting too cold. He could become hypothermic very easily. We're doing everything we can to make sure that he maintains his body temperature. 37.5, so that's not too bad. It's a little bit on the colder side, but still normal. So he does have a blink. We're going to be checking to see if he swallows because he's gaining his reflexes back. Since he's a dog, once he has gained back multiple reflexes, then I can extubate. He never had any air in the tube to begin with, but I am just going to make sure that anything that might have gone in there is out because we don't want to cause any damage when he is extubated. So he's not tied on oxygen. So as he's waking up here, we'll be able to extubate. I'm just going to be monitoring the rest of his vitals. Would you be able to pass me a stethoscope? Danny, would you be? Thank you. I'll just cut that part out. Okay.
Apparently this was discussed at the meeting, so you will understand, and then it needs to be printed, and then the tag needs to be re-tagged, and then Roy needs to be tagged.
Okay, are we, so we are printing the tape now? And then putting that onto the label?
No, fill out the.
So his heart rate right now is 72. As you can see here, he's still taking nice deeper breaths, but they're getting to be a bit more shallow, indicating that he's coming up out of the planes of anesthesia. We're going to be moving him out of recovery once he's sternal.
Thank you, Tina. It's like, she says they'll understand. I'm like, okay, you understand? Okay, good. I understand.
No, you did it really well.
Okay.
Thank you.
But they're on the first desk over here.
Okay, thank you. I'll go through that as well.
We need to be careful that he doesn't regurgitate, so that there was the beginning of a swallow, which is good. Once they can swallow, then there's less of a chance that they may regurgitate and cause aspiration pneumonia. There we go. So that was a nice solid swallow. I'm not too sure if you could see that. So I'm just going to disconnect him here. Push that. There we go. Jesus, that was just gently down on there.
I'm just gonna do
There we go. He lifted his head, so that's coming out. There we go. So now we're just going to make sure that Otto doesn't show any signs of pain. We want to make sure that he has the proper level of analgesia because he's had the post-op Medicam administered. He's whining a little bit, but that could be some dysphoria. Heart rate is up to 112 and he's panting. So I'm just going to check his temperature again, make sure that it's not going down.
This one here is one I pull and run around, so if you do that one, just go real slow with her.
Yeah,
but yeah, Lily, apparently there's a wound with some pus that put it on Dave. Rush her on. I'll keep up with her.
Temperature is remaining consistent at 37.5, which is a good sign. Not losing any heat. Okay.